Now a study is done, and there is a difference in people who are able to buy vegetables with beta carotene and those who are not able to purchase. They found that there is a relation between beta carotene and carcinoma, but those people who are able to buy carrots, they found that they are the poor people, and poor people are expected to get more cancers generally due to a lot of other lower socio-economic conditions. So it is the socio-economic condition of that low standards of life is responsible for cancer rather than eating carrots. So what is that called as? Confounding effect of that other factor. Just like you took coaching, you didn't get seat, but taking coaching may not be always responsible for not getting seat. The reason is you did not read otherwise also. That was the underlying cause. So we give coaching, people get seat because they read otherwise also very well, and incidentally they got. So confounding effect is very important. 30-week-old preterm baby, respiratory distress with the grunting. Then what is the most appropriate management for this? Was surfactant followed by ventilation was among the choices? No. Was the examiner trying to twist between ventilation followed by surfactant, surfactant followed by ventilation? Surfactant followed by ventilation. First thing is baby should survive to receive surfactant, no. So CPAP is the first option. Do CPAP, give oxygen. Then you give surfactant. That is generally the rule. Anyway, I leave basically the idea is examiner want when you come for PGI or All India exam, at least read the topic of managing hyaline membrane disease and come back. So I leave the literature to you that CPAP with oxygen is the first priority any given point of time. This is a challenging question, doctor. Retropharyngeal abscess, is it always on the side of the midline? What are the chances? Fundamentally, if you take retropharyngeal abscess, about 30% of patients have a pharyngeal bulge, but it is not typically midline, because if any mass is in the midline, it is unlikely to be retro, rather it is more likely to be prevertebral, because you have got a retropharyngeal space which is bounded by the raphe, which is created by the superior constrictor muscle, which will prevent retropharyngeal abscess to be a midline mass, is what we need to basically appreciate. So now the question comes, how about dysphagia? Does it always cause dysphagia? This always is a very stupid term. It's like a marriage vow. I will always take care of you. It will never happen. That most of the times you will end up in always harming the partner rather than always taking care, but still marriage vow is I always take care of you until the last breath of life. Whose life? Whose life is not known. Pati Patni or maybe the boy has in his mind somebody else's last this thing. So always if the examiner wants you to commit in the exam hall means generally he means to say don't commit. You are committing means you are marrying to a mistake. Be very sure. So they have done a study. What percentage of cases dysphagia is a feature? Dysphagia is a feature in only 38% of cases. So always dysphagia is not a truth. So I keep option B as a potential wrong statement about retropharyngeal abscess is what need to be basically remembered. Now, raccoon's eyes are a feature of basal skull fracture. So I still think option D is a wrong statement because raccoon's eye in subgaleal hemorrhage is less likely to be. So we should know what is the subgaleal space, what is subarachnoid space, everything. I leave this pictorial for you to review. But now once more the question comes, option A is there. For a keratico-cavernous fistula, fracture skull is the most common cause. Keratico-cavernous fistula, if you take the various causes of it, idiopathic is the most common cause, followed by the trauma. So that is the reason, in one sense, even option A become a wrong statement, but still benefit of doubt we can say D is probably the most possible answer. So most keratico-cavernous fistulas, they are all spontaneous in origin with an unknown etiology rather than any definitive head trauma. That is what we need to appreciate. This is another good question. Transferrin saturation is high, ferritin is high, but there is a microcytic hypochromic anemia. Was there any comment about serum iron in this question? Did they give serum iron low or any remote memory? 20 micrograms was given, okay. So we expect serum iron between 60 to 170, 20 would be low. There is a variant of iron deficiency anemia called as DMT1 mutation. In these people, whenever there is iron deficiency, what do you expect transferrin saturation to be? High or low? So this is one table which you should be very sure, doctor, that percentage transferrin saturation will be typically low in iron deficiency, low in chronic illness, whereas in all the other conditions typically it is high, that is hemochromatosis, hemolytic anemia, sideroblastic anemia and iron poisoning. So this DMT1 mutation is a iron deficiency anemia fundamentally, but it will have a increased serum transferrin saturation along with a mildly increased ferritin level. So here all the three conditions are satisfied. Transferrin saturation is high, right? But in iron deficiency what do you expect? Percentage transferrin saturation you expect. TIBC is different from percentage saturation, don't confuse. TIBC is total iron binding capacity. That will be high in iron deficiency. But the percentage transferrin saturation will be low typically in iron deficiency. But if at all it is not low, but if it is high, then you think of the possibility of DMT1 mutation classically. So mildly elevated ferritin with a moderately elevated percentage transferrin saturation with a low serum iron with microcytic hypochromic anemia. This combination puts in favor the DMT1 mutation as the most potential answer. But still, doctor, one question you will get in the next immediate entrance also on this table. Ferritin given and these values given, this table you have to definitely remember for the tomorrow's exam. It is the LDL levels in the international studies which are most closely correlated with the coronary artery disease risk is what need to be remembered. How many would like to challenge it as HDL? I know, because we need to have out of box thinking. Where we need to also look at the possible unconventional outlook, because both high HDL and a low LDL protective, agreed, but a low HDL is not a low HDL is anti-protective, agreed, but if you look at statistical correlation, it is called as very closely related. If you say LDL is more closely related if you do multivariate analysis, that way LDL becomes the answer. A boy hears aggressive voices, he is having fever for the past 2 days, then he is not like that since childhood. What is it most likely to be? You all agree, delirium? I hope nobody want to say delusional disorder. It will also have all this, but it will have more to do of a long term delusion rather than suddenly appearing. Whereas if you take a scorpion bite child or a typhoid fever muttering delirium, suddenly they will say the IV line as a snake, and they will say the nurse in the as Lankini. Of course she appears like that for you every day, but hey, how she looks like a devil for the child. But they are all very acute with the backdrop of fever is equal to delirium. So this is one of the favorite topics, doctor, delirium versus dementia. This table, I am very sure, once more PGI next week we will have a question, UPSC we will have a question on this. Sixth cranial nerve palsy with increased intensity on T2 weighted image on the contrast. Another dirty question. Because brain tumors radiology means unless you are at least a DMRD or some RD, you will not be sure at undergraduate level. What was there? Meningioma was also there? Meningioma was also there. But I still see the sixth cranial nerve palsy means sixth cranial nerve emerges from where? Midbrain, pons or medulla? Third, fourth is midbrain, 5, 6, 7 is pons. Pontine gliomas can lead to sixth cranial nerve palsy. Glioma is also synonymous with astrocytoma. Okay, and astrocytomas are T2 weighted images, hyperintense. So that puts in favor astrocytoma, but I don't know about this meningioma. I didn't do homework. If you give meningioma, I will also do homework on meningioma, but the option was not given. I'll just check this sixth cranial nerve palsy and meningioma, will they go together or not? We will just check it and come back. But let us see astrocytomas. Typically this is a grade 2 astrocytoma on a T2 weighted image where you can see the presence of hyperintense signal. Why it is not ependymoma? Once more, this is an astrocytoma which is hyperintense on long axis T2 weighted image. Whereas schwannomas are typically hypointense on the T2 weighted image. And if you take ependymoma, it is isointense to hypointense typically, so it also disfavors it. Now, what is very useful for measuring diffusion capacity any given day? It is the DLCO. Carbon monoxide is the one which is basically used for the diffusion studies typically. Why CO2 is more diffusible than oxygen? Because it is more soluble. Solubility factor is very high for it. This is a very good question, practical question. If intravertebral disc is spared, it is equal to metastasis never involves the disc, whereas infection typically involves the intravertebral disc whenever the spinal cord, whenever the vertebrae get involved. Now you can see there is an osteomyelitis with discitis. This kind of a complex osteomyelitis discitis, that is an involvement of intravertebral disc, virtually rules out metastasis. So elderly man comes with back pain, you have done a MRI, he also has a low grade fever, you want to know whether it is infection or any metastasis. First thing you look at is the intravertebral disc involved or not. See, why intravertebral disc is involved in infection? Because if you look at the embryological development of the vertebrae, lower half of upper and upper half of the lower vertebra along with the intravertebral disc get a common blood supply. Hence infection typically leads to disc involvement. Of course you may argue that metastasis come through blood only, no? I mean it's more irrational to expect humans to give a rational logic, but anyway. Now a 70-year-old bladder outlet obstruction is there and prostate is weighing 70 grams, serum creatinine is very high, then what is a very important indication for doing prostatectomy in this given case? So you have medical management versus surgical management. Whenever there is any acute renal failure or acute urinary retention, recurrent infection, they are the main factors that will compel you to do a prostatectomy. Surgical management is what need to be remembered. Pain, fever, jaundice is basically called as the Charcot triad, as all of you know very well. Oh, this is another funny question. Anti-LK1 antibody, LKM2 antibody. Already you will be in a confusion. You will buy a ticket to go to Delhi, S1 compartment, S2 compartment, S3, where is my berth? On the top, examiner will ask you LKM1, LKM2, where is it found, where it is not found. Life is miserable sometimes, right? So now the question here is if you take LKM1 antibody, It is typically a feature of autoimmune hepatitis. It is also found in the case of the chronic hepatitis B. But it is very characteristic of autoimmune. LKM2, if you take, it is seen in drug-induced hepatitis typically. Of course, to add to that, you also have a LKM3 antibody also, which is found in hepatitis D infection. D for doctor. So I leave the literature for you where are these LKM1 antibodies are all found. Now, patient's hypertension, keratoconus, family history of renal failure, classical question of Alport syndrome typically. Osteomyelitis commonly goes to metaphysis, as all of you know very well. Aluminium phosphate is also called as what poison? Rat poison. We used to have one CMO. His favorite question is, what is the antidote for rat poison? Give a cat poison so that it will go and kill the rat inside. So it is generally used as a rodenticide, very toxic. And in casualty you find lot of farmers coming with rat poisoning cases. So now the question comes, it can lead to release of phosphine. It will cause esophageal stricture because of the intense inflammation and the mucosal injury caused by it. Then it can inhibit the cytochrome oxidase, that is how it acts like a cell poison. But does it lead to subendocardial hemorrhage? No. So there is one paragraph on autopsy findings in rat poison. You should be insane to top the entrance. You must be obsessive, compulsive, neurotic fellow, very stickler to the facts sometimes. Now, chemical peeling. So what is the idea behind asking this question? If you don't get seat, at least you can start a beauty parlor. Chemical peeling means you apply some chemicals, remove the wrinkles, you get more money than doing 10 cesareans, 20 hysterectomies. You will find that your beautician is earning more than you. So now we are checking. After 40, all of us get into a sort of comparative grounds of, you have Mercedes, what do I have? At this level it is only you read better, you got gold medal in gynec, I got in obstetrics, only that we talk. So finally if you see, is medicine practice is a lucrative profession? No, not at all. If any of you are thinking that you become rich by practicing medicine, please don't do that, don't prepare for PG entrance. You have a lot of wonderful ways. You can run a hotel, you can run a petrol pump, you can become a very good corrupt politician, good, they are all better ways. How much you will be paid even after doing DM? 1.5 lakh maybe. So you have 2 children, to each of them you have to pay 1 lakh rupees to the school. You have to pay to the, yesterday one of my friend was talking, what is this life, itna saal pade, all entrances we have hit and topped entrances. Finally we discovered 1.5 lakh, where do we live every month, 1.5 lakh in Hyderabad like city, very difficult. So that's the reason it doesn't go well. Learn chemical peeling, do a little facelift of wrinkles, yeah, you get more money. So what are the various things used for chemical peeling? It is a glycolic acid, mandelic, salicylate, azelaic, retinol, cosic, so many. So we don't use phosphoric acid, or you don't do sulfuric acid, well, that amounts to vitriolization. But you can do carboxylic acid, zoleic acid, trichloroacetic acid, oh, lot of acids. So I leave all that literature for you. At least you don't get seat, have a little wrinkle better, so that next entrance you can still prepare. So now let's go to the next question. ER positive breast cancer, how do you treat? It is a tamoxifen. I don't know what were the other options, but it is a very simple question otherwise. Smallpox eradication, why we are able to do? It is not that smallpox has no subclinical cases. Subclinical cases are very much there, but persons with a subclinical infection did not transmit the disease. That is the underlying cause we are able to do. There are a lot of conditions like polio where subclinical cases are still transmitting to others. So if you don't detect them, they are going to continue to transmit. But smallpox is not like that. Smallpox is only clinical cases will transmit, subclinical do not transmit the disease. So there are about some 8 reasons given in Park textbooks, most unread topic called smallpox, but examiner can drill a question on that. Spread of MRSA in hand, best way is hand washing is the most effective way. Perineural invasion of which carcinoma was it given? Pancreas? Adenocystic carcinoma. Oh, even there is one pancreatic adenocarcinoma that also has a perineural invasion, but still that is a very standard question, adenocystic carcinoma. This is a good question, doctor. There is a defective rotation, because of that the cecum is lying in the midline in front of the stomach. So do you call it as a non-rotation or do you like to call it as a mal-rotation? Basically you should know the basic embryology, how the gut basically rotates. The superior mesenteric artery is the axis. You have 2 loops, duodenojejunal loop and the other one is basically called as the cecocolic loop. Cecocolic loop will undergo a clockwise rotation and that will typically bring it inferior to SMA, and the duodenojejunal loop will go superior to the SMA because of the rotation. So if there is no rotation, then what will happen? The cecum will remain unrotated and that will basically place it in front of the stomach. So you still like to consider mal-rotation rather than non-rotation? Probably you can review the literature supplemented. Is there any additional things that are in the frame of the question? Just let me know. That's what I can be able to conclude at this point. Now invert turn foot, dorsum of the foot doesn't touch the tibia is equal to congenital telepoequinovarus, because normally in a child you can be able to touch the foot to the anterior tibia is what you have to basically remember. Halothane is avoided in hepatic disease is a very conventional question. Splenomegaly is a feature of actually polycythemia vera, CML, even primary myelofibrosis also. But in thrombocytosis it is not a very classical feature. Sometimes you may find splenomegaly. So that word sometimes qualifies thrombocytosis is a likely answer for no splenomegaly. Was the potassium given as 4.5 in this? Okay, first of all, is it acidosis or alkalosis, doctor? pH is 7.34 makes it acidosis. Then bicarbonate being 16, low bicarbonate makes it a metabolic or a respiratory acidosis? Metabolic acidosis, because normal bicarbonate is 20 to 29. Now which type of metabolic acidosis? That depends on the anion gap calculation. Generally, how do you calculate anion gap? Sodium plus potassium minus chloride plus bicarbonate. But generally we don't include potassium. So if you take the values given here, 140 plus 4.5 potassium minus 112 plus 16 will give you 144.5 minus 128, which is 16.5. What is the normal value of anion gap between 8 to 12? So, but generally the cutoff value above 12 means 16.5 is definitely above 12, will make it a high anion gap metabolic acidosis. But that is if you include potassium. If you don't include potassium, the value will come to 12.5. 12.5 is on the borderline of the 8 to 12 normal value. So that makes it a normal anion gap, but I think you have to include potassium and make it a high anion gap and make it diabetic ketoacidosis, like you make a tea. So you should be very sure on this. Where do you find Horner medial medullary or lateral medullary syndrome of Wallenberg? Lateral medullary syndrome of Wallenberg, because sympathetic tract will be passing along the lateral medulla, not medial medulla. So I leave to you the various things, drugs, etc., which lead to sympatholysis and Horner syndrome is what you should be very sure. A term gestation baby develops respiratory distress. Then what is that feature would suggest that there is air bronchogram? First of all, term birth is not a risk factor. It is a preterm birth which is a risk factor. You all agree with me? So term birth does not favor you, but air bronchograms, yes, very much favor that it would be the respiratory hyaline membrane disease is what I like to underscore to all of you. It is a part of the criteria. Now generally respiratory distress syndrome, when does it clinically present? Within 2 to 5 hours after the birth. So onset after 6 hours of the birth is not a feature classical for hyaline membrane disease. So what are the 3 important differential diagnoses of hyaline membrane disease, doctor? Transient tachypnea of the newborn. Where do you find that? Typical history of cesarean section will be there. Hyaline membrane disease. Neonatal pneumonias. They are all the important differential diagnoses which you have to basically differentiate. Now child who has got PDA, well, he may have necrotizing enterocolitis and pulmonary hemorrhage, and because of the diastolic aortic blood runoff, he will have a hyperdynamic circulation which lead to bounding pulses, just like anemia, beriberi, PDA, thyrotoxicosis, you have got typically bounding pulses. But is the CO2 washout was the option given? Huh? I don't know what is the basis, but that is the thing that you don't see. Every baby is a future adult. So they have done a study. Will babies will also have some sort of behavior which we can be able to tabulate and grade it. So 6 hours after birth, child cries with the eyes closed and all 4 limbs moving, no chest retraction. What is neonatal behavioral scale? So neonates also do behave, which neonatal nurses know very well. So it was Brazelton who was the one who developed this neonatal behavioral assessment scale. This is not undergraduate question. Too much. If somebody happens to answer means, it's a high time that we should counter check whether a paper is leaked. His mama is working in the exam department. We should check that. So he said 2 states in sleeping with the eyes closed. State 1 means regular breathing, eyes closed, no spontaneous activity except jerky movements, which you see in the neonates. Stage 2 means light sleep with eyes closed with rapid eye movements that you can see under the closed eyelid, with a low activity level with random movements and startles. So this is a typical state called state 1 deep sleep. This is called as light sleep where eyes are moving under the eyelids. Then state 3, state 4, state 5, 6, everything in the awake state with eyes open. So already examiner said it is closed eyes. So it is unlikely to be more than 2. 3, 4, 5 are all awake. So state 1 should be the answer. But state 2 was also given. That become too close a differential diagnosis on a neonatal behavior, which is very difficult, right? State 1 becomes the answer that way. HER2 immunochemistry, why do we use? To know and predict the therapeutic response in the case of the breast cancer, and also to know whether what is that HER2 receptor monoclonal antibody we use called as trastuzumab. So generally one question comes on monoclonal antibody, this time we missed it, but PGI, be very sure, adalimumab, trastuzumab, you have got lot of maps, infliximab, which condition you use the monoclonal antibody. I am very sure next week we will have one question on PGI, if they don't give also we will include, so be very sure. Now in Duchenne's muscular dystrophy, where is the problem? It is the dystrophin gene which is basically defective, which is the underlying cause in case of Duchenne's muscular dystrophy. Now this another dirty question about disinfection protocol. How to wash your kitchen. There is a basic thing he is trying to tell us. What are non-critical devices? What are critical devices? Stethoscope is a critical or non-critical device? Yes? So basically Spalding's classification of the critical care, sanitation care, it is basically called as devices or equipment that come in contact with the intact skin but not mucous membranes is called as non-critical. We don't use steth for mucous membranes unless you are using a transesophageal electronic steth to know the left atrium sounds. I am not talking about that. So bedpans, blood pressure cuffs, etc., they are all non-critical. Then you have got everything else as critical. Now you also have semi-critical. The examiner's question was, do you want a low level disinfection or high level? Actually the semi-critical substances, we basically use a high level disinfection by immersing them in that disinfecting solution for at least 5 minutes. So low level disinfection for semi-critical is a wrong statement. Discussing a little more about this will only make us lose our appetite. So I just leave this cleaning business for you to review that little literature supplemented to you. Now both PT FTD elevated means common pathway. What is the only factor tested by PT? Factor 7, extrinsic pathway. 2, 5, 10 is common pathway. Everything else is intrinsic pathway. So you should be very sure. This is a good question. What is meant by closing volume? What is meant by functional residual capacity? Let us be very sure on our physiology. Very simple, doctor. You all know alveolus, right? Alveoli can be a large alveoli or it can be a small alveoli at the end of expiration. It depends. It depends on what? It depends upon how much surfactant is available. If there is less surfactant, a alveolus typically becomes shrunken because there is a pressure, inward pressure. Surfactant hai to that will decrease that collapsing pressure, but surfactant nahi hai hyaline membrane mein, then that will make the alveolus to become a small sized alveolus. So when a alveolus becomes a small sized alveolus, the air has a tendency. What tendency? It wants to run away from a small alveolus into a adjacent big alveolus. So if the air is sucked by the big alveoli, from the small alveoli, if the air is being sucked away, what happens to the small alveolus? It basically collapses, right? Now we are saying that when surfactant is not there, if the alveolus becomes smaller, the air inside it is sucked by the bigger alveoli. Agreed? But the bigness of that bigger alveoli is decided by what? The amount of the air which is left over at the end of expiration. And the amount of the air left in the lung after the end of the expiration is called as functional residual capacity, will decide that. So there is always a fight between what? Higher the functional residual capacity, higher is the size of the bigger alveoli, so that the smaller alveoli will tend to get collapsed. So what happens in hyaline membrane disease? The functional residual capacity typically becomes smaller than that of the closing volume. That is, even if the bigger alveoli is little big only, it is able to suck the air from the smaller alveoli in the absence of surfactant. So normally what happens? The functional residual capacity is more than that of the closing volume. But in the case of hyaline membrane disease, the functional residual capacity typically become lower than the closing volume, so that the smaller alveoli in which surfactant is deficient tend to undergo collapse. So what is the purpose of giving a continuous positive airway pressure, CPAP, as a treatment of hyaline membrane disease? We want to make the closing volume of that small alveoli to become higher than once more the FRC. That is the idea. Okay. So in summary, wash away all this. FRC is more than closing volume, but in the case of hyaline membrane disease, typically FRC become smaller than that of the closing volume. So that is the typical mechanics of hyaline membrane disease. I leave all that as a short literature for you. Everything is hypercoagulable state, but not lupus anticoagulant, which typically comes happens as an acquired state in the case of those who are having autoimmune SLE. What is a corpus cancer syndrome? It is associated with which carcinoma, doctor? Endometrial carcinoma. So that is the reason those who take lot of fat, who have hypertension, who have diabetes, who have a high estrogen, they are more vulnerable to develop the endometrial cancer. This is a very good question. Extended spectrum beta lactamase producing organisms are being grown. Earlier what was the only gold standard drug, doctor, right from the days of Alexander Fleming? Penicillin. Penicillin के बाद methicillin, methicillin के बाद vancomycin, vancomycin के बाद ESBL, that is extended spectrum beta lactamase producing organisms are growing rampantly. So it is the imipenem and carbapenems which are considered to be the treatment of choice whenever you find ESBL growing. So that is the reason change the cephalosporin to imipenem becomes the treatment of choice whenever the ESBL organism happens to grow in the culture is what you need to basically remember. Now multiple myeloma major and minor criteria is a favorite question of the examiner. Three major criteria: plasmacytoma, bone marrow with more than 30% plasma cells, and immunoglobulin peak more than 3.5, they are all major. Whereas bone marrow with 10 to 30% is minor, and lytic bone lesions are a minor, not a major. So that is the reason major minor criteria of the multiple myeloma, you should be very sure to brush this topic. Now it is a greater petrosal nerve, which is a branch of which cranial nerve, doctor? 5th, 7th, 6th? 7th, good. Greater petrosal, lesser petrosal, and facial nerve palsy. This is one more very high yield topic. Examiner will be mercilessly giving one question on the cranial nerves, especially so facial nerve. So you can check in the paper, any paper you will have one. So greater petrosal nerve innervates the lacrimal gland, provides the secretomotor parasympathetic fibers to the lacrimal gland is what you need to remember. So how does lesser petrosal run? Everything we will discuss anyway. PGI you will have one question, I am very sure. Now what is the mechanism of EDTA? EDTA will basically chelate the metal ion which is present in the various metalloproteinases, which are the enzymes. Carbonic anhydrase is one such example of a metal ion containing enzyme, as all of you know very well. Now what is developed from gastric mesentery? Basically you have foregut mesentery, midgut mesentery, and there are a lot of embryological derivatives out of the two. I leave all that literature for you, but from where kidneys develop, they develop from a different system rather than from the foregut or midgut. So kidneys become odd man out. Of course some of you may say spleen. How many would like to say spleen? But first of all, is it the frame of the question? Was it there or was it given by our friends just like that? It is there, huh? Okay. Now with Valsalva maneuver, which murmur will increase? This is a very common question. So with Valsalva maneuver, will there be a decreased venous return to heart or increased venous return? Negative intrathoracic pressure caused by inspiration will increase venous return. Positive pressure opposite to inspiration is Valsalva. Expiration against the closed glottis will create positive pressure, which will decrease the venous return. So when the venous return to the heart decreases, what happens to the size of the chamber of the left ventricle? It becomes smaller. So whenever the chamber becomes smaller, what happens to the hypertrophied septum? It will go and obstruct the left ventricular outflow tract more. So murmur will worsen. Agreed? So standing will worsen or will it improve HOCM murmur? Anything that makes the chamber size of the left ventricle become smaller will make the interventricular septum to obstruct the left ventricular outflow. You all agree? I think I am coming somewhere in the middle, but we discussed this many times in our regular classes. So standing, Valsalva maneuver or any maneuver which decreases the chamber size of the heart will worsen the murmur of the HOCM. Squatting, etc. They all will cause improvement because they will increase the size of the chamber. Agreed? Now what happens if you give nitrates? Nitrates are venodilators. Because of that the blood becomes stagnated in the periphery. So venous return to the heart will come down. So that will make the chamber size smaller and that will worsen the HOCM murmur. So don't give nitrates for the chest pain caused by HOCM. You can give it to chest pain caused by anything else. Not for the HOCM's chest pain because that will further worsen.